Okay, so we've dealt with solid organ injury. Now the last portion of this talk is going to concentrate on traumatic abdominal fluid. And I like to teach the 3Ds. I used to call it Dixon's 3Ds because I came up with it, but I'm a very humble person, so I'm happy just to call it the 3Ds of traumatic abdominal fluid. So detection, distribution, and density. We've looked a little bit at detecting fluid, but we're going to go into more detail now. Some of this will have relevance to the FAST scan that some of you may perform, although we're not going to focus on that. All I will say about the FAST scan is that if a patient is having a pelvic radiograph in the trauma bay, it's probably worthwhile just pulling your hand away and waiting for the radiograph before you put it back to complete your FAST scan. The peritoneal spaces in the abdomen are really useful in order to understand how to assess traumatic abdominal fluid and the implications of fluid in certain areas. So you remember that the foregut, which has the stomach and the spleen and the liver, does a 90-degree rotation embryologically, so that the spleen goes off to the left and the liver goes off to the right. And what that does is it segments the peritoneal compartment into a big sac, a greater sac, and this small lesser sac gets trapped behind the stomach in front of the pancreas and the duodenum. We call that the lesser sac. It's just got a small opening, the epiploic foramen. So fluid in the lesser sac, it doesn't tend to track there very easily. So if you see fluid in the lesser sac, it implies there's probably an injury to the pancreas or the duodenum, which we'll see later. The greater sac is what usually fills up with fluid when you have a spleen or a liver laceration. Then you'll remember that the midgut does this physiological herniation out of the abdomen and 270-degree rotation before coming back in. And what happens is you get this duodenum stuck down in its normal kind of C shape, and then you get the small bowel mesentery coming from left upper down to right lower. You get the ascending colon being secondarily retroperitoneal coming up in the right side of the abdomen, and then you get the transverse mesocolon and the root of the transverse mesocolon horizontally across the middle of the abdomen and cuts across the duodenum and the pancreas. And this is really important, as we'll see later, because this kind of segments some of this fluid up the top from being able to run into the small bowel. So this right inframesocolic compartment and this left inframesocolic compartment, it's really hard for fluid to track there from a spleen or a liver laceration. What it tends to do is get into the greater sac here and run down the paracolic gutters into the pelvis. It doesn't tend to move in to the small bowel mesentery, so into those right and left inframesocolic spaces. If we see fluid in there, that's going to be due to a mesenteric or a small bowel injury. So this is a normal patient, so I just want to point out where we should be checking for trace fluid on a CT abdomen. So we should be looking in front of the liver here. There's a bare area of liver here which is attached directly to the retroperitoneum and the diaphragm, and so you don't tend to get fluid building up behind the liver. If you see fluid posterior to the liver, that's going to be pleural fluid. So look in front and to the side of the liver for any free fluid. The spleen is not stuck down, so you can look posterior to the spleen and lateral to the spleen for any free fluid. Coming down, a great check area here is Morrison's pouch, or the hepatorenal recess between the right lobe of the liver and the right kidney. So even trace fluid, it's very dependent. It's the most dependent portion of the upper abdomen. So that's where fluid is going to track to in a supine patient. Fluid then, as I said, tends to come down the paracolic gutters here adjacent to the ascending and the descending colon. And then it's going to work its way down into the pelvis. Where's it going to be in the pelvis? Well, this is a male patient. You've got a catheter in here. Here's the seminal vesicles. Free fluid is going to sit up above those seminal vesicles, anterior to the rectum, posterior to the urinary bladder. Okay. If you see fluid which is posterior to the rectum, so in the presacral space, that is extraperitoneal fluid. That is not in the peritoneal compartment. If you see fluid in this pelvic sidewall here, that is not in the peritoneal compartment. That is in the extraperitoneal pelvis. If you see fluid anterior to the bladder underneath these rectus muscles here, that is not in the intraperitoneal compartment. That is in the retropubic space, which is part of the extraperitoneal pelvis. So really important, you should be checking here anterior to the rectum, posterior to the bladder, above the seminal vesicles for free fluid, peritoneal fluid, and it should be really well defined because it's in a potential space. So it should have really well defined margins to it unlike extraperitoneal fluid, which we'll see later, is very ill-defined because it's infiltrating through fat.